Today we're going to talk about red eye and the red flags that come with the red eye to distinguish those that are mild red eyes that could be sorted and treated by the optometrist, and those that should be referred urgently to an ophthalmological A&E. And there are three things that I always ask a patient when they come with a red eye. Is it painful? Do you have discharge? And do you have loss of vision? And that allows you to separate quite well those patients who don't need a referral and is nothing really urgent and can be treated by the optician or the GP, and those that are severe. We're going to go to the infections. Very clearly, if it's seropurulent, if the eye is inflamed, you're going to think of an infection. And then you need to decide whether it's an infection that it's just in the ocular surface or whether it's already affecting the cornea. If it's already affecting the cornea, then there's usually more pain and loss of vision. You may be able to spot it from outside, and in those cases, if it's a microbial keratitis, then they definitely need to be referred. If you can see that there's an infiltrating the cornea or there's a hypopyon and there's also this pain and loss of vision, you need to think that the infection is deeper, not just conjunctiva, but deeper. And it could be the bacterial, which tends to evolve quicker, or fungal, which tends to be a bit more chronic and a bit slower progressive. But in both cases, they tend to be related to contact lens or trauma. Those things need to make you think this patient needs to see an ophthalmologist. The one that is an emergency is the hyperacute one. It can melt the cornea in hours, and this is the gonococcus. It develops really quickly. In just a few hours, the patient shows a bad conjunctivitis. There's a lot of discharge, and there's a lot of hemorrhages underneath the conjunctiva. They need to be sent to the STD clinic. So they need systemic treatment. They need drops in the eyes, but they do need the systemic treatment. And they also need tests to rule out chlamydia too. So remember about this one. This is the one that it is a proper emergency referral. A microbial keratitis which doesn't have discharge is the hepatic one. It usually doesn't cause that much pain. It's more like the discomfort in the eye. There's a bit of pain, but it's not significant pain like it could be with a bacterial or a fungal. The patient may have had it before, and sometimes they know it's coming back. But if it's the first episode, look for vesicles in the skin, which will suggest that it is hepatic. Have that cobalt filter in your office, apply the fluorescein, and then you'll get this shape usually. You can treat this with cyclovir or ganciclovir. Even if you get it wrong, it's not going to damage them. It would damage them if you prescribe steroids. We're also very happy to see these patients in the A&E department before they start any treatment. And then the other herpes, which is the varicella zoster one. And it can cause keratitis, it can cause uveitis. And there's one thing, if you see a patient with shingles, then you need to look for, and that should warn you that that patient may be having at the same time an eye problem. Hutchinson. If you see a patient with shingles and they have the tip of the nose affected, it's the same innervation than the eye, so they need to be, they may well be having a uveitis or a keratitis at the same time. If the patient is a contact lens wearer, the eye actually doesn't look that bad from the examinations, but the patient is in a lot of pain, then it may be amoeba. Typically, the amoeba causes much more pain than you would think from the examination. If we see them in this stage where the epithelium is affected but the stroma is still clear, then they respond much better to the treatment. We can remove the epithelium and send it to microbiology, and we can start the treatment, and they do tend to get better. Again, do not prescribe steroids. There are two types of allergic conjunctivitis that the ophthalmologist definitely needs to see. One is if it's affecting children and it's significant and it's ongoing, because it can be a vernal keratoconjunctivitis, usually in patients who are atopic, so eczema, asthma, the whole thing. And they will need topical steroids, and they will need usually cyclosporine or sometimes other things. And again, if it's in an adult, if it's an atopic patient, so you see that they have significant eczema, and their symptoms don't get better with just the usual antihistamines, and then they need to be referred, because these patients come with many other issues in the eyes, and usually because of eye rubbing. They're also at a higher risk of keratoconus because of the rubbing, and they are at a higher risk of hepatic keratitis, which actually is many times is bilateral. So these patients will receive from us not just the anti-allergic, but steroids and cyclosporine, sometimes the protopic also in the eyelids, or tacrolimus inside the conjunctiva. These patients, because they're quite dependent on steroids, they can develop glaucoma secondary to the steroids. If you see a patient who's using steroid creams on their face, even if they're not putting any inside the eye, their pressure can go high. So if a patient depends on those creams in the long term, it's useful to check the pressure from time to time. We're reaching the one that really needs to make you send the patient urgently. Moderate to severe pain, significant visual loss, and usually no discharge, need to make you think of these things. Angle closure glaucoma and scleritis. In the scleritis one, the patient is in a lot of pain, and also this bluish tint that you can see in the sclera. And they tend to be rheumatological patients, but sometimes they don't know about it. So they need to be referred so that we can rule out rheumatoid. Obviously we can treat it, but we can also rule out vagus or something that actually requires systemic treatment. They can have keratitis of non-infectious type, or they can have uveitis, inflammation inside the eye. These are the things that just need to be sent. The things that the patient refers are significant pain around the eye. It tends to be like a throbbing pain, like a headache. It just spreads this way. The eye is red, he has lost vision, and they see colorful halos around the lights. Many times there's nausea and vomiting, and that's because of the very high pressure. The pupil, if you check the pupils with your torch, it won't be reactive. It's usually mid-dilated. And if you have a slit lamp, you'll see that the iris is a bit bombay like this. They need treatment urgently, obviously. Perceptal cellulitis versus orbital cellulitis. So the main thing is to look at the eye. Perceptal cellulitis will be usually an infection of a insect bite, or it may be from a sty or a trauma. But the eye itself is normal. So the eye will move normally, the visual acuity will be normal, the conjunctiva will be normal, the pupils will move normally. The orbital one is the one that comes usually from the sinuses, very often, which spread to the orbit, and then they cause this proptosis. The eye doesn't move, the vision is decreased, and the movements are restricted. And this needs IV antibiotics. And the endophthalmitis. So as I said, if there's ocular surgery in the history and the patient is having significant discharge and loss of vision and pain, it can be an infection inside the eye after the surgery, and they need to be referred urgently. Just for you to remember the warning signs, again, visual loss, pain, significant discharge that doesn't resolve soon, and if there's recent trauma or surgery or contact lens involved. If it's something that needs to be seen fairly urgently, which is those red flags that we talked about, then a Moorfields A&E is open 24/7. So the easiest thing is to give a letter to the patient which has the examination that the optometrist found, and then advise them to go to Moorfields A&E.